you. Thank you very much. And I'd like to start by thanking Congresswoman Christensen for convening this panel. Pfizer has participated in it for many years. Usually we've got a Pfizer representative up here talking about Pfizer Helpful Answers, which is our free and discounted drug program. And we are still managing that program. It's still available to patients, but we've got something really cool and exciting that I want to introduce to you today through a video clip. And for anybody who had a question or had a statement that they wanted to make and didn't have time to, I invite you to join the Pfizer dialogue that I'm going to introduce, because imagine if this conversation could keep going all day, all night across geography, and imagine if some of the patients that we're talking about could actually join the conversation. And that's what this program is all about. It has a simple name, it's a provocative name. It's called Get Old. With life expectancy continuing to increase and 1 in 5 Americans expected to be over the age of 65 in the next 25 years, we believe there couldn't be a more important time to get informed about what it takes to get old and to enjoy getting old. At Pfizer, we say that we have therapies that add years to our life, but also life to our years, and that's what this dialogue is all about. Get Old is a new multi-year initiative. It's developed by Pfizer and conducted in partnership with a dozen leading advocacy organizations, some of them that are represented here today. We're working with the Alzheimer's Association, with Easter Seals, with the National Black Nurses Association, with Women Heart and the National Coalition for Women with Heart Disease, and that's just to name a few. We want to inspire and activate people of all ages to reconsider what it means to get old. And we believe that this type of dialogue can help us identify new ways of addressing disparities in health, because the goal of the program is to get people talking about aging based on their age, their gender, their ethnicity, their emotions about aging, their experiences. And because it's being done through social media, they're expressing themselves in all kinds of different ways. So I'm going to tee up the video that will hopefully inspire you, but you won't really know what this is all about unless you log on to www.getold.com, and hopefully you'll think about adding some content and looking at the content that's already on. Thanks a lot. www.getold.com. Get Old.
What I want to talk about is the state of cancer screening, and in particular with a focus on how screening policies are influencing outcomes in our broader society as well as in the Black community. So here's some facts. Cancer is the second leading cause of death in the United States. 1 out of every 4 people in the United States will die of cancer. There were 1.6 million new cases of cancer every year in this country, and 580,000 Americans will die from cancer this year. African Americans suffer from the highest death rate and the shortest survival of any racial and ethnic group in the United States with regard to most cancers. However, there is good news. Cancer survival is on the rise. What you have here is a chart, and if you go from the left to the right, from the 1970s to the 2000s, you can see that cancer survival has risen from roughly 50% in the 1970s, when there were roughly 1 million cases, to 67% now, 2 out of 3 in the 2000s, when there are 1.6 million cases, which can be attributed largely to the increase in the size of our population over the last 30 years. More people are surviving when they get cancer, and that's good news. If you do the math, I would estimate that about 250,000 people are probably surviving who would not have survived had they been diagnosed with their cancers in the 1970s. It's the size of a pretty good-sized city, and that's really good news. So how has that been accomplished? In broad strokes, it's been accomplished in 2 different ways. The first way is through better screening. The other approach has been better therapy. But screening has had a huge impact. Screening saves lives. The gold standard example of this is the example of colonoscopy. Colon cancer and rectal cancers are very important causes of cancer incidence and mortality in the United States. We can expect that about 50,000 people will die from colon cancer or rectal cancer in this year. The 5-year survival rate with early detection is 90%. In people who undergo, and that's for people who undergo screening with colonoscopy so that it's picked up early. If you pick up these cancers at a later stage, the 5-year survival is just under 70%. That's a huge impact. And this is a test that is rarely used in our society, or at least not used enough, with 20 or 30% of Americans getting colonoscopies at age 50 when they should be getting them on a more regular basis. However, that's a simple example. Screening for other cancers is really not so simple. Let's talk about breast cancer. So the task force recommendations came out in 2010, and one of our best investigators, Jean Mandelblatt, was the lead author on this study, which demonstrated, if you look at the entire U.S. population over time, that adequate coverage is obtained in terms of reducing the incidence of breast cancer that can be dangerous by doing mammographies beginning at age 50 and doing them every 2 years until the age of 75. You may recall that that caused quite a furor. And it actually led to re-examination of breast cancer screening guidelines and actually culminated in the recommendations that were adopted for breast cancer screening studies to be done at the age of 40. Irrespective of the task force recommendations and how it ultimately turned out, there's no doubt that there's been a steady decline in breast cancer mortality over the last 20 years, with 5-year survivals that was in the low 60% ranges 50 years ago, and they're now 90%. Black women are actually screened just about as frequently as white women are, but the outcome is worse. And we're not sure exactly why there are worse outcomes. This is a subject for research that's very important to do. Delays in getting treatment, other socioeconomic factors are certainly part of it. Access to appropriate care is a part of it. And there's a clear evidence that the cancers that arise in some black women are more aggressive than those that occur in white women, with different biological characteristics that we need to understand better and treat better. So what can we do about this? And there are many efforts being undertaken around the country to deal with this. At Georgetown Lombardi, we have a nationally recognized program in breast cancer designed to understand the fundamental biological basis of cancer, to try and address these very important health disparity issues. And one of the ways we do that is through the Capital Breast Care Center, which is designed to provide access to potentially life-saving mammography for women who are underinsured or uninsured in the DC capital region. Let's turn our attention now to prostate cancer. The task force recommendations for this disease just came out this year and actually recommend against prostate screening using PSA levels for men. This is a disease with 240,000 cases a year and 28,000 deaths. What's really interesting is that this is a disease where not every prostate cancer is destined to kill the man who has it. It's quite clear that there are good prostate cancers and bad prostate cancers, and we don't understand what they are. What we do know is that black men have a higher rate of developing prostate cancer, and the death rates from prostate cancer are more than twice as high in black men. So there's a huge screening debate. How do we identify which man should be screened, and when we identify a cancer, which cancer should be treated most effectively? So what we need to do about it, and what we're doing about it at Lombardi, is studying important biological differences that might underlie different outcomes in prostate cancer. Lung cancer. The U.S. Preventive Task Force concluded in 2004 that there was insufficient evidence to recommend any type of screening for lung cancer, which is the most common cause of cancer death in the United States. Over 225,000 cases will occur in 2012. And in contrast to the other diseases I talked about, the significant majority of people diagnosed with lung cancer will die of their cancer. So this is an important cancer that we need to do something about. And one of the things we obviously all care about is reducing the risk of lung cancer by reducing the rate of tobacco use in our society. But people still smoke, and those people still are at terribly high risk of developing cancers. The National Lung Cancer Screening Trial, in which Georgetown Lombardi was a major participant, one of 33 centers conducting it around the country, did a very interesting clinical trial where people who were at the age of 55 or over, who had a significant smoking history of more than 2 packs a day, were randomly assigned to either get a low-dose CT scan of their lungs or a chest X-ray to determine whether or not the more expensive CT procedure would give a better result. And to everyone's surprise and delight, it was found that the use of the CT screening reduced the death rate from lung cancer by 20% in those people who were screened. So a low-dose CT scan in the properly selected individuals is life-saving, okay? We don't know yet whether this will translate into NLST guidelines into U.S. Preventive Task Force guidelines that these screens should be done, but I can think of few interventions that could be more powerful and more important. And we are doing something about this with our MedStar Georgetown partnership. We are offering lung cancer screening for people who meet the appropriate criteria recommended by the U.S. by the National Lung Cancer Screening Trial. And this screening is offered throughout the MedStar network. It also provides us with a teachable moment. Teachable moments are very important. If we have somebody who comes to see us who has a concern about maybe developing lung cancer, gets screened, even if the good news is that there's not a problem, it gives us an opportunity to talk to them about their cigarette smoking addiction and to perhaps help them do something about it and develop a screening plan for the future. It is critical. That money is critical. We cannot sustain our momentum if we don't have that kind of resource in order to be able to do the research. So continued public support for research, screening, and cancer care is vital to save more lives. I want to close with a personal comment. I was delighted to be asked to present today at this event for many reasons, but one of them was that one of my patients was Congressman Donald Payne, who recently died from colon cancer, as many of you know. And it was one of the great privileges of my professional career to take care of him. Now, because of the HIPAA violations that you have to worry about with this, I wasn't going to say anything about it, but I ran into his brother Bill outside as I was walking in here, and we chatted about it, and he told me how delighted he would be if I mentioned my connection to his brother to remind all of you that this is not an abstract problem. This is a real problem. It affects us. It affects all of us. And we need to do something about this problem. And in some ways, this is not a racial disparities problem. This is a human problem. And in Bill's memory and in recognition of in Don's memory, and in recognition of the wonderful man he was and all that he represented, it's a deep honor for me to be able to be here today. Thank you very much.
As a physician, I feel much more comfortable if I did have slides, but I was told, give a 5-minute talk. So I thought that was an unlikely invitee as a representative of Merck because I only joined Merck 6 months ago. Nevertheless, I know quite a bit about hepatitis C. I was professor of pediatrics at Children's Hospital of Philadelphia and director of the viral hepatitis program for the last 20 years. I recognize that hepatitis C is common. I would see children in my office that had gone to give blood as part of their high school drive, get a call from the Department of Health and be told that they had this. You track it back and it's their parent who had it. I've taken care of children who shared a razor in a shower and they contracted it from one of their friends. And I've certainly, in the most tragic circumstances, been referred children who have hepatitis C when their parent was diagnosed with terminal cancer. And that would be liver cancer related to hepatitis C. So hepatitis C is common, and I think most people don't realize how common it is. The newest CDC guidelines put that in print, and there's an estimated 3 million Americans who have chronic hepatitis C, and the majority of those people are unaware. For 20 years, there have been programs that have been tried to identify people through a focused approach. So unlike lung cancer screening, the newest CDC guidelines come up with a program that is one size fits all. When you rely on physicians to come up with very specific approaches, such as look for tattoos, IV drug abuse, and other risk factors, they either don't recognize what they're seeing or they don't ask the question. And even more importantly, at least half of people who have hepatitis C don't remember some sort of event that may have triggered the infection. They may have been somebody who had a one-time event many decades earlier, and it's a very slow disease. Or they may have been, like my patient, just shared a razor in a shower with a friend and didn't realize that the friend was infected. So the data from NHANES and what has come out in the CDC publication shows that 1% of the U.S. has a positive antibody. The most interesting part of the new guidelines is its simplicity and its effectiveness. By looking at birth cohort, we know that more than 3% of those born between 1945 and 1965 have had or have an infection. Although 3% is common, ethnic minorities have an even higher rate, in particular blacks, who in this same age group have a 6% prevalence. So it's extraordinarily common. So why do we care now, and why are we asked to join a panel about, in my case, cancer screening? How do the CDC guidelines impact this? So liver cancer is very closely connected to viral hepatitis. The vast majority are due to either hepatitis B or hepatitis C. Curing hepatitis C will impact the incidence of liver cancer. It's the third leading cause of death worldwide and the 9th leading cause in the U.S. From 2001 to 2006, the cancer rate has increased. And what is surprising about that is that even though our knowledge has improved about hepatitis C, the rate has increased, and it's because a cohort of baby boomers are aging and cancer is becoming more common. Of those with chronic hepatitis C, 2 to 4% each year will develop hepatocellular carcinoma, the most common liver cancer that will kill you from viral hepatitis. So one of the reasons why the CDC guideline is so important is that now we're at the point in history where chronic hepatitis C is curable. The virus was only discovered in the late 1980s, and the first treatments were only effective in 5 to 10% of cases. Over the next decade, it improved to approximately 50%. And in the most recent, since 2011, a new medication came on the market, which can reach cures that are closer to 80%. But that medication, boceprevir, also has a lot of side effects. It is also inconvenient to take, and it is really only best for the healthiest of people with chronic hepatitis C. There are new medications coming along, and the new expectation is that 90% or more will be cured by the new medications, and that the hope is that the newest medicines will be easy to take. They'll be as easy as curing a strep throat. That may be a slight exaggeration, but the course of therapy will be something that isn't years of treatment. It isn't even a half year. It'll be several months. So I'll come full circle, and I've always cared for people with chronic hepatitis C. I made a career shift last winter because of my interest in being at that forefront in order to cure hepatitis C. This is one of the few diseases where we will be able, with good screening, bringing people to care, knowing that you can cure it, move from a disease that is very, very common to one that is hopefully eradicated. Merck has a 20-year history of being involved in these sorts of things. We were the first to bring the first medications to the market, and hopefully we will be the next wave where things will be cured. So we have many medications and better to come. So to briefly review the CDC guidelines, the CDC recommends that a simple blood test that checks for antibody be the test that is given to all people who were born between the years of 1945 and 1965. If you do that, you will detect 2/3 of those who actually have hepatitis C in this country, even though that birth cohort only accounts for 23% of the population. The people more recently born are unlikely to be affected. And in that birth cohort screening, it is twice as likely if you're African American, Black in this country, to have chronic hepatitis C. So thank you.
I was going to share a story about my wife, Keisha. Rutledge draft, and it's always good for everybody to get a chance to see a picture of her before we get going. And it's kind of there somewhere. Let me see if I can maybe get at least move it along so you can see that. Or I'll just give you a description. My wife passed away in December 27th of 2011, but at 38 years old. At 38 years old. And she passed away from lung cancer. Again, you'll be able to see the video. It's going to download, but she is a graduate, electrical engineering graduate of Clemson University. While she was there, she was a rally cat. She was, amazing dancer. Before going to Clemson, she graduated from high school in 3 years. Was a state champion in high jump in South Carolina. Beautiful woman. People ask me what my favorite team I played on. I'm up here in Washington, and you would think I just have to say that, but I can't. I have to say Carolina because that's where I met my wife when I was playing with the Carolina Panthers. So healthy, strong. Actually worked as a pharmaceutical rep for Sanofi Aventis. Healthy, working out, just dancer in shape. And December of 2010, all of a sudden, she had a little shortness of breath. And this little shortness of breath combined with she was training for a 10K, challenging me to train for a 10K with her. I'm saying, you know what, I play football. I run, 100 yards, and at the most, that's a bad play if I'm running that far, That's a bad play. I'm a defensive guy. I'm supposed to go and go hit folks. And she said, "No, I want you to get out here and do a little bit of running." So, little shortness of breath. People ask me all the time. I finished up playing in 2010. They ask me, "Do I miss football?" And that's a very difficult question. It's a very difficult question. If I just say it outside of my life, outside of the experience, outside of my wife, I have to say, "Oh, I missed the game." If I say it outside my body, I say I missed the game. But if I were to say that I was up here in Washington and absolutely fortunate that I ended up being released, because what that meant was November of 2010, I was home for Thanksgiving. When most people are getting all excited about watching football, you either play on Thanksgiving or you are practicing on Thanksgiving if you play in the NFL. So I was able to be at home. So at the beginning of December, if you look at a football season, we kind of break it up into quarters. And December is really the fourth quarter of the season. That's the time where you secure a playoff berth or really kind of secure your job for the next year. So it's very serious. When people are saying, "What do you have to play for?" Even if you're not going to the playoffs, you still are playing for your job. Well, in that serious time, as it would relate to football, if I was playing at that particular time, it was a serious time because that's when my wife was getting a little shortness of breath. And rather than being someplace else, not being down in Atlanta where we were living, I was right there with her. I was right there with her when she went for, she said, I'm just going to go to my primary care doc. Went to her primary care doc. And she had a little shortness of breath. He said, "Oh, well, let's do a little antibiotics. It's not too bad, not too much. But let's just get let's just get a chest X-ray just to see, just to see. There should be no problem. Let's just get a chest X-ray." So that chest X-ray that was right there at, right about December 20th, 2010, came back, and then what it said was that she had a mass on her left side. This woman that's in shape, that grew up in a small town in South Carolina, Williamson, South Carolina, right outside of Greenville, Anderson. Grew up in a small town, went to Clemson. Y'all know that's out in the middle of nowhere. Went to Charlotte, lived most of her time in Charlotte. And Charlotte is the only city that has been referenced as a clean city over and over again. So a mass in her left lung. Well, after that's right before Christmas that we had found that out, and I was I was hoping that I'd have one of the pictures. I have her on my iPad. Actually, it's her iPad, but we were able to spend Christmas together. Again, not playing, was able to spend Christmas together, and I say those points because unfortunately the lung cancer story is crazy. It's a story that most people don't know. A story that you see the deaths. I mean, 160,000, by far the biggest killer. And who knows that? If we went down and just, these educated people in here, if we just went and asked, so what's the biggest cancer killer of women? What would people say? They would say breast cancer. But what are the numbers? What are the numbers?
Not close.
Not even close. Lung cancer actually kills more than breast, prostate, colon, melanoma, liver, kidney, all of them combined. So if you ask who's the biggest killer of men, people would say prostate cancer, but we saw the slide, it's second. But not just second, but second by far. So that's what we were dealing with. We were dealing with cancer, lung cancer. What is this lung cancer? Because, when we look at some of the information, most people think, well, if you don't smoke it, you can't get it. Well, no, if you don't smoke, you can get it. And unfortunately, because of some of the screenings or lack of screenings up until this point, when you do get it, you get it late stage. And that's the case that we were in. Keisha was chest x-ray. Before Christmas, we come back. She has a biopsy, finds out that it is cancer. We're hoping, because you hope that if it's early, if it's stage 1, there was a reporter here at the ABC here in D.C., had a little bit of pain, went in and spoke with her doctor. They had a CT scan and found it early, stage 1. She was back 3 weeks later on the news. Her name is Greta Cruz. She was back on the news. She was treated at George Washington. Amazing. So we were hoping, man, maybe that's something that can happen. Unfortunately, it wasn't. Unfortunately, it was too much like the 75% of the people that have lung cancer, and that is that they're diagnosed late stage. They're 3, they're 4. When we got our full diagnosis, it already had spread to her liver, to her renal, say adrenal, bone, and to her brain. She was just training for a 10K. But that's what lung cancer is. She fought it. We went through some of the promise with lung cancer is therapies. I know we didn't talk too much about it because we're talking about screenings. There's these new therapies. One therapy that just was approved this last year. It's for an ALK mutation. I've got a chance to know all these things now because of this long year of fighting since my wife passed. But a new drug where they can give somebody a pill and you don't lose your hair. Don't lose your hair and you can extend somebody's life. A new drug that was approved last year for an ALK mutation is crizotinib, but there's another mutation, it's EGFR. They have a Tarceva that works for that. These are new. These are hope. These are hope. Last year's screenings, they were approved. Hope. But hope that's coming. Hope that's not here but needs progression. Hope that needs push. Hope that needs a whole bunch of push. Because the state of lung cancer is that someone like my wife Keisha, can have stage 4 lung cancer and progress through this. Where this year, she felt like, all right, we're fighting it, we're getting it. The chemo is working, it's kind of working, it's kind of not. And we were blessed to be able to be married last year. And a video will be shown. We fought together and were able to be married, but she actually passed away again a month after actually that we were married in December. And we've continued this. One of the things that was so amazing about my wife is that at our wedding day that we actually launched our initiative that is changing the face of lung cancer that we are continuing right now and educating folks. And she knew at the wedding, we were sharing our story, sharing her story more. She cared more about other people. She cared about making sure that somebody else would not have to go through the same thing. And that's not just about just saying it. It's about people that are doing that. And that, number one, comes with changing the face of lung cancer and making sure that people see a face on lung cancer. Making sure that they understand what the numbers are and the amount of deaths that there are in lung cancer. And then understanding that there is a stigma out there, and that stigma is because lung cancer is told through a smoking commercial too often, not through a lung cancer commercial. That lung cancer commercial says that there are smokers. Yes, but there are a whole bunch of former smokers, people that decided and understood a long time ago that smoking wasn't good for them, that are still at risk. And then there are plenty of folks that are never smokers, between 15 and 20% that are never smokers like my wife. These numbers are huge, and they're unacceptable. But the promise, and there's promise and there's hope. And I have to say it, it's not going to bring my wife back, but there is promise and there is hope. The hope is in the therapies that I said, that there's a EGFR mutation, there's an ALK mutation. To give you guys a picture of what that means in terms of hope is that I had a chance to meet a young man in Cleveland, and he's 25 years old, never smoker, lung cancer. 25 years old, but the difference between him and my wife is that he has an ALK mutation. And that difference in that ALK mutation means that he was diagnosed last September. And he is in med school, working on programs at the Cleveland Clinic right now. And it also means that 3 weeks ago, actually about 4 weeks ago now, when I was driving down the road from Charlotte to Atlanta, that I got an email. And the email was that I'm getting married. I actually was saying that I asked my girlfriend to marry me, and she said yes. She said yes. She stood by him the whole way, but she said yes. And I said, now when are you guys getting married? He said they're getting married in 2014. That's the promise. That's what research is doing. That's what's pushing things ahead. We see the screenings. The screenings are new. Up until last year, there really wasn't. I mean, there were people doing some of the screenings, but it hadn't been proven. Now, if you guys saw the slide, it said heavy smokers. It did. Well, that was because that is the highest risk group. And so you had to look at that group first. But the hope, the real hope is that all that is a beginning step. The beginning step on the way to get into where someone like my wife, who doesn't have any symptoms, does not have family history, that we will have something that will allow people like yourselves, people like everyone in here, to be able to be screened by just possibly being some blood, by being able to spit in a cup or something, that would allow everyone in this room to be screened. Because lung cancer is not just a smoker's disease. Lung cancer is a disease that anyone can get. And it's important, just like this director of Georgetown Lombardi Cancer Center said, that it takes the public funds. It takes the public support to make that happen. So unfortunately, the video did not play. I want to encourage you guys, if you can go to our site, chrisdraftfamilyfoundation.org or Team Draft, you guys can see it and see the video and really have a chance. I'm going to get a picture so you guys can see my wife before we head out here. And you can see that she is you, that she's you, that any of you guys. And we have to fight for it. We have to fight for all the people in this biggest cancer killer. So thank you. I know we're going to have some questions, but thank you for letting me share a little bit about my wife, Keisha. Thank you.